Good morning, everyone, and welcome. I don't see the crowd of the students. Can I see whether my group student, Davishas, the current year 5 are here? Hands up. Another 6, 1, 2, 3, 4. Where is another missing? Another 2, 1, 2. Yes, you are. All right. Good morning, everyone, and welcome. Thank you for joining the Department of Pediatrics CPC today to discuss a topic of, hang on, the unresolved, can you see on the poster? The unresolved, okay, here. The unresolved infection, thinking beyond the obvious. Our CPC presentation is structured as follows. One, the case presentation by a pediatric trainee, Dr. Aqilah, based on the abstract that we provided to her. Two, involvement of the audience, particularly the students, postgraduate, undergraduate, anyone that who is present in this auditorium for an interactive sections of the case presentation via Mentimeter. We hope it works. It was a little bit of glitches last night. Third, presentations by field experts relevant to the case. We have a panel of experts at the front here, including our external expert from National University of Singapore, Prof. Emeritus Prof. Kwa Tuan Jong, which actually have been very kind to step in last minute on Sunday night when our initial invited speaker from the USA couldn't make it because she met with an accident and had a humerus fracture. So we are very delighted, that our distinguished speaker and discussant from Singapore has been agreed to be with us today. So it's going to be a very rich presentations and materials that you can obtain from this presentation, followed by discussions, Q&A, and last but not least, quiz for the undergraduate students only with personal prizes from me myself. And before we conclude, we're going to wrap up with some take-home message. So this CPC will run through 1.5 hours, although that we might finish earlier. So stay tuned until the end of the session. It'll be very rich information, and you can hopefully you can get from this CPC. So without further ado, I will invite Dr. Aqilah to present the case. Can you see that?
Okay, good morning to respected chairperson, esteemed colleagues, and also members of the floor. My name is Aqilah and I'm a pediatric trainee, and I will present today's Grand Clinical Pathological Conference. It is regarding AR, a 1-year-old girl who presented with a 1-week history of right neck swelling and 3 days of fever. She was diagnosed with a right neck abscess and underwent incision and drainage. The pus culture grew methicillin-resistant Staphylococcus aureus (MRSA), and histopathology examination reported an abscess wall tissue. She received 5 days of intravenous vancomycin and was then discharged with oral antibiotic. At follow-up in the clinic 1 week later, she reported intermittent fever after discharge. On further examination, she was found to have residual palpable right cervical lymph nodes with splenomegaly and a raised C-reactive protein of 117 milligram per liter. Ultrasound and CT scan of the abdomen showed multiple hypoenhancing nodular lesions in the spleen with enlarged splenic hilar lymph nodes. Subsequently, she was referred to the infectious disease team with an impression of a partially treated MRSA neck abscess and possible splenic involvement. At this stage, she was readmitted and treated with broad-spectrum antibiotic and vancomycin. Blood cultures and tuberculosis workup were negative. Serum galactomannan was positive at 1.83 nanogram per ml, and she was started on antifungal for suspected invasive fungal infection. The antibiotic was de-escalated. During admission, she developed a left ear discharge and was diagnosed with otitis externa. She also had frequent loose stool. On second week of admission, while still probable, She developed villous patches and plaques over both lower limbs. A skin biopsy showed leukocytoplastic vasculitis, possibly related to infection or drugs. The treatment was continued while further investigations were conducted. She also developed anemia and received packed red blood cell transfusion during the ward stay. During the 4th week of admission, she still has intermittent and fever and was found to have thrombocytopenia. The peripheral blood picture examination showed no blast and no evidence of hemolysis. Examination findings at that time shows temperature febrile with 38 degrees, pulse with 120 beats per minute. BP was at 90 over 50 millimeter mercury. Bilateral cervical limb adenopathy was felt with multiple sizes. No axillary or inguinal limb adenopathy. There is a rash in the scalp and groin, and there is a hepatosplenomegaly with a liver 3 cm and a spleen of 5 cm. Cardiorespiratory and neurological system was normal. The growth of weight and height is at the less than 5th centile. Other background history for this child is she is a full-term birth child with a normal development and up-to-date immunization. She's the only child of non-consanguineous parents, and there was no previous history of hospitalization.
Right. So now we come to the stage of before Dr. Aqilah gives her differential diagnosis. Perhaps you can hearing from the history presentations itself, you can put in your differential diagnosis. Any one of you, okay? Oh, good, it works. We give you a few seconds more. I'm expecting, more than 2, 3, 4, 5, 6. Yes, done. Okay, I'm aiming about 70, 80 respondents. Yes, come on. You just put in whatever that you feel that it can fit into the case presentations itself. I have 67 respondents. 71, 72. That is good. So you understand that, the biggest font size is the most frequent answer that being given by the audience. Right, great. Yes, Dr. Aqilah, you want to continue with your presentation?
Going to the differential diagnosis for this patient, the first differential diagnosis for this patient is hemophagocytic lymphohistiocytosis, which the child fulfilled 3 out of 8 criteria: fever, splenomegaly, and bicytopenia. However, there is a need evidence of hypertriglyceridemia, hypofibronogenemia, hemophagocytosis in the bone marrow examination, low natural killer cell activity, ferritin more than 500, and elevated soluble IL-2 receptor. The second differential diagnosis for this child is a Langerhans cell histiocytosis, multisystemic with risk organ involvement, whereby the child exhibit most of the symptom of LCH. He has a rash on the scalp and groin, otitis externa, limb adenopathy, hepatosplenomegaly, and bicytopenia. The reason why I put this as a second differential diagnosis is because it is quite a rare disease, especially in the children. The third differential diagnosis is a non-Hodgkin lymphoma because the child presented with a bilateral firm non-tender cervical limb adenopathy, systemic symptom with a fever and poor growth. However, I need to confirm with the previous growth parameters and hepatosplenomegaly, but there was no bulky nodal mass in this patient. The fourth differential diagnosis is acute leukemia because the child presented by cytopenia, hepatosplenomegaly, and persistent fever, but the points again is no blood cell seen in peripheral smear, but it may indicate an early phase of acute leukemia. The fifth differential diagnosis is the systemic juvenile idiopathic arthritis SJAIA with macrophage activation syndrome overlap, because it can present with bicytopenia when there is bone marrow infiltration and inflammation. So it can present also with prolonged fever, hepatosplenomegaly, limb adenopathy, and also rash. However, there is no arthritis whereby the child did not present with any recurrent joint swelling or any avoidance of weight bearing prior to the presentation. The sixth differential diagnosis is chronic granulomatous disease, as a child presented with MRSA abscess, catalase positive organism, invasive fungal infection, poor growth, loose stool, lymphadenitis, vasculitis rash, and also thrombocytopenia, which may indicate sepsis. However, there is no consanguinity in this patient, and it is more common in boys in the X-linked hereditary. The second last differential diagnosis is the disseminated tuberculosis, as it is very well spread in our society nowadays. But the points to it is limb adenopathy, prolonged fever, poor growth, hepatosplenomegaly, and also loose stool if there is any gut involvement. However, the initial workup for tuberculosis is negative, no evidence of previous exposure to TB patient, and no history of chronic cough. And the last differential diagnosis for this child is Epstein-Barr virus infection, whereby the patient presented with fever, limb adenopathy, hepatosplenomegaly, bicytopenia, but I need more history on regards to the previous episode of exudative tonsillitis prior to presentation. And this child presented with a lymph node and splenic abscess, which is quite rare. It usually doesn't happen in Epstein-Barr virus infection.
Dr. Aqilah, can you go back to your first slide of differential diagnosis? Maybe we can, do some, if you have any questions to Dr. Aqilah, you can always raise up your hand and ask, rather than you want to keep it at the end of the presentation itself. I myself would have some quick questions for you on your list of differential diagnosis, okay? If you look at the Mentimeter by the students or the audience that answered the question, answered their differential diagnosis and yours, my question to you is, if you were to rearrange your differential diagnosis according to the most likely diagnosis, and least diagnosis, okay, would you do that, or you would just keep to how that you are presenting your differential diagnosis now?
As I read more further in this case, I would put the Langerhans cell histiocytosis on the first differential diagnosis, because in my slide itself, I couldn't find any points again in regards to this diagnosis.
Okay,
so they will be
is HLH is common in children?
Is not in common in children.
How many criteria that you would need to diagnose HLH? You put here fulfill 3/8.
Usually we need 5/8 criteria.
5/8 criteria. Does this, go to your second slide? Does this case presentation could fit, high on the list of infantile or acute leukemia?
Given the age of the child, she can present with the child can present with the similar presentation if the child having infantile leukemia.
Okay, if the rashes that you have been described, could that rash appear, that type of rash appear in this in patient with acute leukemia or infantile leukemia?
But for the rash itself, it's very peculiar for a patient with infantile leukemia.
The rashes?
Yeah, the rashes. For me, it's a bit, it's not usually presented in patient with acute leukemia.
So the rash can appear in acute leukemia. The rash that been described in this case can appear in acute leukemia or cannot appear, or very rare, or what?
Very rare.
Very rare. What type of skin or rashes that you would expect in acute
I would expect
leukemia?
some petechial rashes.
Petechial rash. Do you agree with petechial rash in infantile leukemia? Any one of you? Yes, Dr. Jia Ning? Blueberry. He said blueberry. What is blueberry? Have you heard leukemic cutis? Any of the students heard leukemic cutis? How you describe leukemic cutis? Can it a violaceous rashes like what being presented here?
Yes.
Yes. All right. So you still would want to keep your differential diagnosis here, right? Okay. Right. Do you want to move on to the next slide? Right. So here we have another Mentimeter. What investigation you would like to perform to assist, in your diagnosis? So let's see if we have, any response from the floor. Good. Oh, good. A good level of knowledge. All right, we have 58 out of 94 respondents. Maybe work out. 63 out of 94. It's very great interactive session here, and you all are very knowledgeable. Can be scary. 67 out of 95, we have another 10 seconds. All right, great. So if you look at the spread of the investigations results that the floors are thinking, the most frequent answered here is bone marrow aspiration to find. BMAT stands for bone marrow aspiration to find. And the lymph node biopsy and followed in hierarchy, the peripheral answers that being written or being projected in this slide, it's in the screen itself. So those are relevant, but how when you highlight, when you rank that, which one would be your priority? So this is where that, we can listen to the subsequent presentation. But Aqilah, do you want to continue with your presentation?
Yes. So going towards the investigation for the child, for age to fulfill the criteria of more than 5, we need a serum ferritin, what I will expect will to be high. Triglyceride will be raised, fibrinogen will be low, liver function test will show elevated transaminases. Bone marrow aspiration and trophine biopsy is important in this case, whereby it will show hemophagocytosis. To diagnose a LCH with multisystemic with risk organ involvement, the patient need bone marrow or skin or lymph node biopsy with immunohistochemistry. If there is a presentation of a positive CD1A Langerine or S100 plus histiocyte with eosinophilic infiltrate, it is a pathognomonic of a Langerhans C-cell histiocytosis. Skeletal survey or bone scan mainly to look at osteolytic punch-out lesion in imaging, especially at the skull and also long bones. Going towards the lymphoma, we again need an excisional lymph node biopsy where the lymph node will show non-Hodgkin lymphoma changes. Lactate dehydrogenase, LDH, and uric acid will show high LDH and also uric acid turnover. Acute leukemia is common in this current age. Thus, we need bone marrow aspiration will show more than 20% blast. Flow cytometry will show immunophenotyping, whether it's a lymphoblast or myeloblast. LDH and uric acid again will show high cell turnover and it will be raised. And mixed lineage leukemia, MLL gene, especially we are highly suspecting of infantile leukemia. SGIA with macrophage activation syndrome overlap will show high inflammatory markers, and you can produce so the similar investigation result as an HLH, whereby we show high ESR, CRP, high ferritin, high triglyceridemia, high triglycerides, and also low fibrinogen. At the same time, anti-nuclear antibody and rheumatic factor is usually negative, and bone marrow aspiration will yield no blast or malignant cell. chronic granulomatous disease because of the child recurrent abscesses and also showing immunocompromised state. The child needs a neutrophil oxidative burst test, dihydrodermine or nitrobutyltrazolium, which show absent or markedly reduced oxidative burst test activity. Genetic testing for CYBB or other NADPH oxidase complex gene, and serum immunoglobulin profile will show normal immunoglobulin. Disseminated TB, because we don't know what's the exact TB investigation done during the earlier presentation in the case. So we may need to repeat blood for gene expert tests whereby it can be positive. Acid lavage for acid fast bacilli will show positive FFB. ESR CRP will be high, Mantoux test will be positive, and lymph node biopsy again will show granulomatous inflammation and caseous necrosis on histology. Chest X-ray is needed in this case to look for any pulmonary or nodal calcification, and Epstein-Barr virus infection will show EBV, and IgM serology will show positive in acute infection.
Next slide of investigation. Yes. Can you elaborate a bit? I will just scribble a little bit when you were presenting just now. So what do you mean with flow cytometry? Flow cytometry is just a system.
I was meaning about immunophenotyping to look at whether it's a lymphoblast or myeloblast.
What sample?
Immunophenotyping.
What sample?
Bone marrow examination in
bone marrow.
Yes, immunophenotyping.
Your MLL?
MML gene also will to look for, because I am highly suspecting of interfantile leukemia. So
what sample?
Sorry, Prof.
What sample?
Bone marrow, Prof. Bone marrow for bone marrow.
I mean that students are also have
okay, Prof.
to. Can I just ask you about the SGIA? Is this common in children, particularly at this age?
Not common in children.
Okay. Is there any diagnostic key investigations that you would want to do given ESR and CRP is an acute phase reactant? So it can be raised in any condition, particularly also if you're talking about GIA, right? So is there any diagnostic investigation that you wanted to highlight that would point towards GIA?
It's usually a diagnosis of exclusion. So after all the investigation is negative for the child, mainly we will have to refer Rumato for SGIA.
Is there any particular diagnosis to say to support GIA? Any criteria to support GIA?
There is a ELA criteria, but it's usually mainly a symptomatic.
What are the criteria? How many of this one that you need to have? Do you need to have ANA and also rheumatoid factor?
No, it's mainly a clinical diagnosis whereby the child have to have fever for more than 2 weeks, arthritis, and also
that investigation-wise is mainly on clinical diagnosis, or there's any specific lab investigation for GIA?
No.
Maybe you want to elaborate. Maybe you want to rethink about that rather than putting every single investigations on the list. Okay, I'm just what catch my eye that you were saying that supporting finding very high ferritin, fibrinogen, and TG. So you would ask all these parameters are raised.
The fibrinogen will be low, the ferritin and triglyceride will be high.
So correct me if I'm wrong, that you wrote there very high ferritin, fibrinogen, and TG. What do you mean?
It's usually when there is a...
What do you mean? Do you mean that high fibrinogen as well, or what from your writing?
Sorry, it's actually low fibrinogen.
Low fibrinogen. So it's low fibrinogen instead of high fibrinogen. Can you go to the next slide, please? All right. Can you elaborate a little bit on disseminated tuberculosis key investigations? Are you going to do all these investigations, or are you going to carefully choose which investigation that you want to do?
For this patient, I would proceed with blood for gene expert test and proceed with the lymph node biopsy with the Zillness then.
What is gene expert test?
Gene expert test is usually is actually a blood investigation for TB to look for if there is any presence of tuberculosis.
So how would that be superior than Mentu tests and, you know, the traditional package investigations that we usually send when we encounter patients to have TB in a different setting of hospital resources? Is it a tertiary resources or, you know, a district and those things? How would you select carefully rather than blurting out everything that you want to send for tuberculosis? Tuberculosis is common in this area, certainly, right? So how would you choose? Are you going to do all these things with chest X-ray as well?
I will want to proceed with the Mantu test first. Then if it's negative, to do a gastric lavage for this age is quite difficult. But if I were to choose, I would like to proceed with the Mantu test, chest X-ray, and then blood for gene expert test, because I assume during the initial step, we already proceed with the acid pass bacilli.
Would Mantu test help you in this case? Would Mantu test results help you with this in this case?
If it is
positive, what does it tell you? Would it help you with the diagnosis of active TB? Okay, we can get some help later on. But do you want to elaborate a little bit about gene expert test? Maybe this is new for some of the audience, especially for the undergraduate. For particularly about disseminated TB, you're talking about extra pulmonary TB? Yes, okay. So do you want to take a little bit of the gene expert test? Is it blood test?
It's a
sputum test or anything?
It's a blood test. It's
blood
a blood
test.
Yeah.
So no other sample that can go with gene expert test. Is that right?
Yeah.
Yes. Okay. All right. So I think we will going to correct you that, because for gene expert test, you also can get sample from often that, you know, you take a sputum sample if patient has sputum, but you also can have a tissue, a lymph node tissue to do the gene expert test. All right. You can also have a peripheral blood for the gene expert test. Do you want to repeat a little bit? What is gene expert test again?
Gene expert test is a test to look for TB patient, especially at the extrapulmonary.
Okay, we have our ID expert, you know, in the panel of discussant later. So he might help us to give a little bit of information, which I think for gene expert test over other things, whether you're going to send everything of the investigations TB, then we will see how it goes. Because, you know, this is very important as TB is prevalent, you know, in our region, correct? Okay. Any other questions? Sorry, any questions from the floor? No. Okay. So I would invite Dr. Loh. No need. To show some of the investigations result, and Dr. Aqilah might meeting to interpret the results. Yes, please. So we give you a serum.
Aqilah, there will be three slides on investigations. So this is the first slide. You want to go through the investigations and maybe you want to interpret the
results. So in regards to the investigation, the serum protein is low. ESR is low as not expected for this disease to be in a patient with TB and also in patient with having high inflammation. Liver function test shows elevated liver transaminases. Therefore, it may show that there is a liver involvement in this case. INR is slightly on the higher side. Therefore, maybe it's because of the coagulopathy secondary to liver involvement. Fibrinogen is low, so triglyceride also is high, and also LDH is not raised in this case. Other than that, C3, C4 is on the normal side, and ANA is low. Proceeding with the IgG, IgA, and IgM. So the IgG, IgM, and IgA is at the IgM is at the high level, maybe because of the inflammation and so infection going on. IgA also is increased. IgG is not raised. Neutrophil oxidative burst assay is normal. Gastric lavage FB times C is negative. Gene expert test Mycobacterium tuberculosis not detected. Lymph node pass for TB smear shows no growth. Melioidosis is not raised, and EBV IgM is negative. White cell count is 19, is on the higher side, mainly maybe because of the infection, ongoing infection. HB is of 6.5, and also platelets is 55, showing that the child has cytopenia with anemia and thrombocytopenia. BMA smear and trophine shows no blast, no lymphoid population, or no evidence of hemophagocytosis or non-hematopoietic malignant infiltration. Peripheral blood immunophenotyping also show no evidence of elevated double alpha or beta T cells.
So what's the last investigation point towards to?
So going to all this investigation, we can point out already there is no HLH, there's no acute leukemia, there's no acute lymphoma, but we still need a lymph node biopsy for this patient. Also, there is no TB, disseminated TB, and also EBV is not in the list, and also SIJIO also is likely not in the list.
So what is the most likely diagnosis? I think you get the floor to answer that.
Okay. So we need to
the next slide.
Okay. So
the next slide, sorry.
This one, Prof.
Okay. So your peripheral blood film immunophenotyping, have you interpreted that the last investigations? The last investigations. What is that last investigation?
So putting out all the
last investigation on
the last investigation is peripheral blood immunophenotyping, show no evidence of elevated double negative alpha or beta T cell.
So what that?
So putting out all these
what that point towards to negative and elevated double negative T cell.
So there is no acute leukemia in this patient. Okay.
Yeah, actually the peripheral blood we signed want to know some autoimmune lymphopoietic syndromes. This is not marrow immune. This is a peripheral blood immunophenotyping. So I think we go to the last slide. We get the floor on the investigations. What is your most likely diagnosis? Can you click on the next slide? Next slide.
Next slide.
Ada.
Tak boleh keluar apa?
Tak boleh keluar.
Dia keluar kat sini. Tak keluar kat sini. Sini.
Oh, it's stuck. Sorry.
No, maybe the actual is on.
No, yeah, it's hang.
No, my Mentimeter account is on, right?
Is that a view? Okay.
Yeah. You can put down your most likely diagnosis for this patient after hearing or knowing all the relevant investigations results that been presented and interpreted. Can I ask who answer ICH is what? That is the abbreviation? Huh? Tak, I. ICH. Apa tu? I might not know. Anyone answer ICH? Can you just let us know? Share with us. Huh? Apa? LCH. Okay, salah tulis. What is LCH? I don't know. Okay, I'm waiting for a little bit more response. So this is a little bit more of, trickling on your mind in the early morning. Okay, let's see what your thinking is. I have 42 response. Someone go up on your adrenaline. Ten seconds. Right. So, Dr. Aqilah, when you have when you have interpreted those investigations results and those some of the specific investigations that being informed to you, what is your most likely diagnosis, or what would be your diagnosis, final diagnosis for this patient?
Okay,
Before final diagnosis, most likely diagnosis.
Okay, putting out all the investigation, also the presentation of the child. My most likely diagnosis is the multi-system Langerhans cell histiocytosis with risk organ involvement, specifically the bone marrow, liver, and spleen, which categorize the child as having high-risk LCH.
High-risk LCH.
Yes, high-risk
Okay.
LCH.
So what diagnostic investigation that you want to do?
Okay, so this diagnostic investigation, again, to repeat, is needing the tissue biopsy for any of the bone marrow. For this patient, she's having a persistent lymphadenopathy, so I think likely we need a tissue biopsy from the cervical lymph nodes.
All right, so student, if you look at your, most frequent, answer to the most likely diagnosis is LCH, and some have, spell out that. So if you combine that, that is the most, likely diagnosis. And LCH with disseminated MRSA as a compounding as well. Right, thank you very much. So next, in the interest of time, I would invite Dr. Priyatharisini to present some the tissue biopsy results as being requested by Dr. Aqilah.
Thank you, Prof. Hamidah, for inviting me. And a very good morning to all professors, consultants, and colleagues. So I'm Dr. Priya, pathologist from Histopathology Unit, HCTM. So we received a specimen labeled as cervical lymph node. Grossly, we saw multiple fragments of brownish tissue measuring 8 millimeters in aggregate diameter. So this is how the tissue appears in low power magnification under the microscope. We can see it is fragmented, and there's this area, there's two zones here, this pinkish area, which is representing fibrocollagenous tissue, and it is being surrounded by a bluish area. This area gives us a tinge of bluish. It basically tells us this place is densely populated with cells. What type of cells? We have to scrutinize in higher magnification. So on a slightly higher magnification, we can see the proliferation of these cells. They are medium-sized, and they are arranged in diffuse sheets. We can also see mild to moderate infiltrations of mixed inflammatory cells, such as, okay, this is a small cell, right? We can see round nuclei, densely stained with scanty cytoplasm. These are the mature lymphocytes. And we can also see some cells like here, these ones, they have multilobated appearance. They are basically one nuclei, which is connected by fine chromatin, and it is giving us the multilobated appearance. And these are the neutrophils. So also scattered among them are small cells like this. a bit orangeophilic cytoplasm. Okay, these cells, this is a much higher magnification. And they have this orange appearance because they are filled with granules, and those granules have affinity for acid. And so they become the eosine stains quite strongly and giving us this appearance. Those are the eosinophils. So now in this magnification, we can also see the lesional cells. They are basically giving us irregular nuclear appearance, and some of them have convoluted nuclei. In some of the cells, we can see horizontal creases, like these ones. You can see there's one line here, like this. So these cells, these features, they give us the coffee bean appearance, and we call them nuclear grooving. And the nuclei is basically having fine chromatin, and they are being surrounded by pale eosinophilic cytoplasm. So at this point, we have seen the morphology of the cells, and based on the availability of the immunohistochemical stains in our center, we can perform some of them to help us to determine the lineage of the cells and also to exclude some of our differentials. So based on the morphology of the cells here, they basically give us the appearance of histiocytes, dendritic cells, Langerhans cells. Somewhat they have this size. So we did one CD68 immunohistochemical marker. This is a primarily histiocyte marker, and it is positive in this case. So at this point, we have to also exclude some of the histiocytic neoplasm. Histiocytic neoplasm is quite rare, but in this age group, sometimes we do see Erdheim-Chester disease, positive histiocytosis, and some diseases like that, Langerhans cell histiocytosis. So we have to perform additional stains. So S100 is another immunohistochemical marker. We can say they are positive based on the stain picking up in the nuclei and as well as some of it in the cytoplasm. So to call it positive for S100 stain, we have to have both positivity, which is, in this case, it's positive. And then we have another marker, which is CD1A. CD1A is, here it is showing strong membranous positivity. See this like surrounding, it's strong membranous positivity, and they are usually positive in Langerhans cells. So unfortunately, in our center, we do not have Langerine, so we didn't perform the stain. Our Chi67 is a proliferation index. It's basically it's roughly estimating to 50%. It's not included in these slides, but we have also done CD20 and CD3 immunohistochemical stains. Those are basically for B cell lineage and T cell lineage. And from this, we didn't see any clonal proliferation that directs us towards lymphoma. So with these findings, these morphological findings and stains, we concluded this diagnosis as features consistent with Langerhans cells histiocytosis. Thank you.
Thank you, Dr. Priya. Right, before we call our pediatric radiologist, Dr. Aqilah. So now it's confirmed LCH, and you mentioned about multi-system organ involvement. Any other specific investigations that you want to do for the wrist organ involvement in LCH?
So in LCH, once the tissue biopsy is confirmed, I want to proceed with imaging, specifically using the MRI whole body contrast to look for any osseous or extraosseous lesion.
What kind of osseous lesions that you're looking at?
This osseous lesion usually will involve the skull and long bones. It will present as a osteolytic punch-out lesion.
All right, you mentioned just now in your list of investigations, you want to do a skeletal survey and bone scan.
Yes.
All right, which one would you do?
And
you mentioned just now you want to do MRI.
If our center have availability of MRI whole body, I would have to proceed with the MRI whole body first.
Why?
Because one is because it has less risk of radiation, and secondly, it can portray more of the extra osseous and osseous involvement.
Okay, great. Any other investigation you want to do?
Any other investigation you want to do is because it's multi-systemic, like cell histiocytosis. I would like to look at the chest X-ray also to look at pulmonary nodules.
Right, you mentioned about high-risk organ. Any other high-risk organ investigation that you want to do? Particularly when you look at the MRI just now, what side of the anatomical side of MRI that you want to pay attention in regards to the LCH, multi-organ involvement?
Multi-organ involvement, It can involve the brain.
Yep.
yeah.
So what you want to look at the brain?
And in the brain, we have to look at the pituitary stalk.
So why?
Because it can infiltrate the pituitary stalk and it can cause diabetes insipidus later
Great,
on.
thank you. Can I invite Dr. China Ying, our pediatric radiologist, to give us, the radiology perspective of LCH in this case, and also the general aspect of it, for your informations.
Thank you so much, Prof. Hamidah, for your kind introduction. Good morning to professors, consultants, colleagues, and also students here. So let's go through, and I'm very grateful that Dr. Aqilah has given us a brief introduction, and what she said is actually correct. So this is a study being done by someone, Kim, JR. The study involved testing on how sensitive and how good is the different modality. So they have picked up skeletal survey, bone scan, and MRI whole body. I put this up to illustrate the best imaging modality that should be performed if your centers has the availability of it. Okay, if you look at the skeletal survey, the sensitivity is not, it is 0.57. It's not too bad. It's not too bad, but it's not too great. The skeletal, the missed skeletal lesion is around 37% missed. All right. But compared to the bone scan, actually the skeletal survey do better than the bone scan. All right, but extraskeletal lesion, of course, skeletal surveys, sometimes we can see enlarged liver or splenic shadow, but in bone scan, they miss entirely 100% of the lesion in the study, which is the 18 lesion, they miss all the 18 extraskeletal lesion from the bone scan. All right, so how is MRI whole body? MRI whole body actually scored the best. You can see that the sensitivity is very high, and they only miss one skeletal lesion. They did not miss any extra skeletal lesion, meaning that if your solid organ involvement or your CNS involvement can be picked up with the MRI whole body. So the MRI whole body has been increasingly used for during the initial stage of the disease diagnosis, as well as to follow up the treatment response and so. But the only drawback for MRI whole body is that currently the MRI whole body, the imaging of the pulmonary part is still suboptimal. So we can either supplement it with chest radiograph or CT thorax. So there is also FDG PET CT scan, which sometimes they use to detect a residual active lesion if it's needed, but anything that has high glucose requirement or consumption, it will light up in a PET CT. So sometimes this is also non-specific. All right, so for this patient, the imaging findings, the patient was referred from other hospitals, so the images from the initial investigation was not available in our system, but this is what we have. So if you can see that the patient chest radiograph, the lung volume and soles are good, and we do not see any cystic lesion or any nodular lesion. The most we see is a little bit of interstitial infiltrates at bilateral perihilar region, which is very non-specific. It could even happen in the normal infection. So in this patient, there is no lung nodule and there is no cystic lung lesion, and there is also no pneumothorax. We did an ultrasound abdomen at some point in the time, and we can saw that the striking features is the patient has very massive splenomegaly. And in the spleen parenchyma itself look quite heterogeneous, and there is this peripherally located lesion, which after we put on the vascularity color Doppler, there is actually there is no color or color Doppler flow within it. So this is the MRI whole body performed for the patient. As you can see that this patient has very prominent sulci, the ventricles also slightly enlarged. So there is a generalized volume loss, I would say, of the brain parenchyma. Right, and this is the T1 images and this is the T2 images. We do not see any intra-axial lesion for this patient. This is a post-contrast study, and I purposely cut it in the midline so that we can see the pituitary infundibulum. It is enhancing, but it is not thickened. So this enhancement is normal. So for this patient, the infundibulum of the pituitary are not involved, and also there is no other extra-axial lesions or leptomeningeal lesion. So this is what happened in a cervical lymph node. Remember, the patient presented with a neck swelling. So these are the lymph node. This is a T1 weighted image. The lymph node look a little bit hypo-intense. And this is a T2 weighted image. This is the lymph node. Adjacent to it is the jugular vessels. And this lymph node also appear hypo-intense on the T2 images. And also further down, there are other lymph node in the rest of the level, which is also hypo-intense on the T2 weighted image. And this is what it looked like in the T1 fat set post-contrast image. There is a little bit of enhancement. This is our hilar vessels in the lymph node, but the corticals of the lymph nodes are not that enhancing. So this is what we had in the thorax, and you can see that there is not so much of lung parenchyma architectures that we can visualize in the MRI with the current sequence that we have. The main thing here is just some atelectasis at the basal region. Sometimes it can relate it to sedation, sometimes it can relate it to infection. And this is what is happening in the abdomen. This on the left-hand side here is a T2 weighted in a fat saturation sequence. We call it STIR in a coronal cut. And the middle one is actually T1 weighted image. But it's T1 weighted image because it's a gradient in a gradient echo sequence. And you can see how dark the spleen has become. All right, so this is the spleen, which is very large, extend even down to the left iliac fossa here. All right, so this splenomegaly with very heterogeneous parenchyma appearance. It is dark on T2 and also it's very dark on these T1 images. On the other hand, the liver is also enlarged for this patient. So this is a hepatomegaly for the patient, but the signal intensity of the liver parenchyma is still rather normal in the T1 weighted images. And also at the midpoint of the midpole of this spleen, we see the peripherally located weight-shaped lesion again. So I will detail the lesion in the subsequent slices. So this is where we cut the lesion, and we can see that on the T2 fat saturation axial cut, the lesion is bright, and also this is the diffusion restricted images. And on the high B value of DWI, this lesion shows bright signal intensity with reciprocal hypo-intensity on the ADC. To make it in the simple term, this is what we call a restricted diffusion. So there are certain pathology that can give us restricted diffusion in the MRI. For one thing, it is the first thing that comes to us is a cytotoxic edema, or what we usually call infarct. All right, and also sometimes because of the proteinaceous and viscous content of the pus collection, they can also show restricted diffusion. In some tumor where there is high cellularity, also the restricted diffusion can occur. All right, and the T1 fat saturation image, this one is a pre-contrast, and post-contrast, you can see that there is not much of enhancement of this lesion. All right, so it is not a high cellularity, and there is no rim enhancement around this lesion to suggest that this is a collection. So putting all together, there is actually a small splenic infarct. All right, because this is a weight-shaped, periphery located, restricted diffusion. There's not so much of rim enhancement. So, and also this patient had multiple lymph nodes, not only at the cervical region. We can see that at the para-aortic region, there are multiple lymph nodes. I put on the different sequences to show that these are the vessels and the lymph nodes are located there. All right, so all these are not the varices, because sometimes they look like varices if you only have a few cut of the images. But these are the lymph node that is quite hypo-intense on the MRI images. So before I go to the general aspect of LCH, so we can see that our patient, the interesting about this case is that there is no skeletal lesion. Okay, there is no marrow involvement for this patient, which is not very common for LCH. The splenomegaly gives us a very, very peculiar signal intensity, which is very, very dark on T1 and T2 weighted image, suggestive of, for my postulation, it is because of a hemosiderosis. All right, because in the process of LCH, there can be infiltration of the vessels and there can be congestion of the vessels and blood within the spleen and can cause a hemosiderosis of the organ. Right, same goes to the lymph node. Okay, so the general imaging findings in LCH, before we go through that, the involvement of the LCH, 80% of the patient will have skeletal involvement. So unlike our cases. And skin involvement is also quite common. Pituitary involvement is one of the most common CNS involvement in LCH, and we have a liver, spleen, hematopoietic system. These three are being called as a risk organ, and we have lung involvement in 15% of the cases. Lymph node is not that uncommon, it's quite common as well, and we have some other CNS involvement other than the pituitary. So this is how the skeletal survey or the skeletal involvement it could look like. All right, first of all, we will, this is what we call a vertebra plana. This is a collapsed vertebral body that it looks so flat, right? This is called a vertebra plana. And when we see this in the normal x-rays, when we see this in our daily x-ray reporting, we should raise the concern of whether this patient have underlying hematological disease. Most importantly, whether this patient have a LCH. And you can see that the example that I've shown here, this patient has multiple lytic skull lesion. And the skull lesion is so well defined, and sometimes we can even see a beaver shape from the lateral projection of the skull here. And most of the time, the LCH skeletal lesion come with soft tissue swelling. So you can see that actually there is some soft tissue component there. All right. In the long bone, it looks more of a lytic lesion. Sometimes they are not very well defined in the long bones, and sometimes they could even have periosteal reaction. The central nervous system, as I mentioned, this is the example. On the left-hand side here is a pre-contrast study. This is the post-contrast study, and you can see how thick and enhancing the pituitary stalk is, which in our patient is normal. All right, this is another cases. Not only the pituitary stalk is enhancing and thickening, there are also multiple perivascular enhancement within the brainstem. This is how the pulmonary LCH will look like if the patient have involvement in the lung. It depends on the stages of the disease. So in the early stage of the disease, it will be more nodular, okay? Most of them are micronodular, but sometimes they could be about 5 mm in size. As they progress to the later stage, some of the nodule will start to cavitate, all right? And then the cyst formation will come. And the pneumothorax is not an uncommon complication. Okay, for example, you can look at this patient in the center here, the bilateral chest tube is being inserted because this patient developed bilateral pneumothorax. A causophrenic angle involvement is quite common in pediatric LCH, unlike the adult. Adult, usually we call it classically sparing this causophrenic angle. So the take-home message is the MRI whole body is increasingly used for the initial and also subsequent evaluation. So think of MRI whole body, if your centers has the facilities as well as the expert to report it, but however, it's a little bit inadequate for the lung assessment. Thank you so much.
Thank you very much, Dr. Chai, for the very informative presentation. Now I invite Dr. Loh to present the progress of the patient and quickly summarize that before we move on to our discussion with our external experts as well. And it could be one quick presentations from Prof. Kwa as well. Yes, Dr. Loh.
So I think you hear from all the presenter, I think AR is a patient is diagnosed with Langerhans cell histiocytosis involving the multi-system and involve the wrist organ as well. So I think we're repeating many times, you know that wrist organs are hematopoietic, which the patient have anemia, thrombocytopenia, although the bone marrow findings was normal in these patients. And there was present of enlarged spleen and also enlarged liver. And at the same time, also the patient have hypoproteinemia and hypoalbuminemia, but no transaminitis in this child. Other than that, other side that have been involved also is ear, where this child, you still remember, have multiple episodes of ear discharge, have otitis external, otitis media. These are the potential symptoms of LCH. And these sites are, we call it CNS risk, as what we discussed in the previous presenter. There's a risk of patients getting a diabetes insipidus. But I want to highlight here, although the imaging do not show any thickening of the pituitary stalk, doesn't mean that the child have no risk of getting a DI, especially during the active phase of LCH during the treatment time. And these DI are permanent. And other than that, this child also have lymph nodes involvement, the loose two, maybe a GI involvement, and the skin involvement as well, although we do not biopsy the skin. So other than the HPE or histopathological finding in this child, we also sent for NGS panel for the biopsy, and it turned out the child have a BRAF V600E mutation positive, which we'll be talking about it on the subsequent presentations. So what happened to this child? So this child required treatment as this patient had multi-system risk organ. So it treated with LCH3 is an international protocol by international group, the Histocytology Society. This LCH3 regime, as highlighted here, this mainly for the patient with a risk organ. They include the main three phases: first cycle or first course, then evaluate on the disease status, which I'll talk a bit more on that. Then whether this child needs second course of the treatments or not, followed by 12 months of continuations of treatments after evaluations. So there are 2 points of evaluations for these patients. So these patients, during the first course treatment, the main treatment modality are oral prednisolone, then high dose for 4 weeks, and the child will receive a weekly vinblastine. So that's a main backbone of a treatment in LCH, steroid and weekly vinblastine. And the subsequent account, I just want to show that what happened during the treatments. You can see here that the HP are persistently low. They require almost weekly PEG cell transfusion. HbR3, the highest are 5.6 throughout the 6 weeks of treatments. And platelet was initially low, which is 12, and subsequently is not transfusion required. Just want to summarize how this child respond in the past 6 weeks. The French LCH study group had come up with the disease activity scoring, which I want to show here, so easier for you to understand, or we can objectively score this child and see whether is it getting better, status quo, or progress. All right. So this child have a pre-treatment score, the total score. You can see here fever, skin, nodes, liver, spleen, albumin, transfusion requirement, red cell, and platelet. Total score are 13. The higher the score means the higher the activity of LCH. So for the post-course treatment after 6 weeks, the score dropped, but not significantly, is 10. So mainly in a part of resolved hypoalbumin, and also reduce in the platelet transfusions. So what is the disease status in this child? So it had a score of more than 7, and there's not much of the decrement of score, but there's no increment on the scoring as well. So it considered as an active disease, intermediate, or some people will say it as stable disease. So this patient have an active disease, intermediate, so you need a second course of the steroids and vinblastine. So the child receiving a second course of steroids and vinblastine, but the steroid are much more of a pulsing rather than a continuous daily steroid. So again, show the count. You can see that the HP are improving. PEG cell transfusion are not required at this stage of course 2 of treatments. The course 2 disease activity on your right hand side, post course 2, you can see that there's a significant drop in terms of your total score. And now this child still have active disease, but active disease in a better state where you have a significant drop of the scoring of more than 4 points. So what happened? Yep, it's good. We don't need to think of whether we need to intensify or salvage these patients. It's improving. So we continue with maintenance treatments of 12 months. So the maintenance treatment again is steroids, prednisolone, vinblastine, with more spacing out kind of a time point, 3 weekly, and the child was continually have oral 6-metacopurine continuously throughout the 12 months period. So during this continuation treatment, the child show progressively improving clinical state where there are normal blood count, no more fever, liver, spleen size are not palpable anymore after 4 months into the maintenance. So currently this child have been in remission for the past 8 months, and the child have a normal neurological development. I think there's some concern in the whole body that this patient have a generalized brain atrophy. So LCH, I think throughout the presentations, you have been heard that LCH is rare, right? So although it's rare, but the most common age of the presentations is during infancy. The slide here, it shows that incident rate per million populations per year. And the x-axis is the age of the patients. So for those less than 1 year is a high peak of the LCH presentations. And the incident decline when the child grown up, all right? And it's not a common disease in adult where it's only like 1 to 2 cases per million populations per year. So in general, the median age of the presentation for LCH is a disease of childhood. They present at age of 2.5 to 3.5 years old. And they are slightly male predominance, 1.2 to female ratio. So again, what is LCH? Early days, LCH are called histiocytosis X. X means unknown, X val, all right? The reason that is labeled X because they don't know where is these lesions come from. The lineage of origins are unknown. And later on, I think Dr. Priya also talked about with the stain, you can define the lineage of the cell. So they managed to define that these lesions are mainly a Langerhans cell. So the X are replaced with the Langerhans cell. So it's called Langerhans cell histiocytosis. Again, there's a lot of debates. Again, is this a cancer or not? Or this is not a cancer. So they are debating, is this a neoplasia? Or this is just an immune dysregulation, mean like a hyperinflammatory state. So which one is it? All right. So just a bit about physiologies of Langerhans cell. The slide above here just want to show the Langerhans cell mainly reside in the epidermal layer or your skin, and is the cell are from your prenatal stage, are from your fetal, for your fetal liver and your yolk sac, and all these Langerhans cell will reside in your in the skin. And when any acute event or injury happen at the skin, then the Langerhans cell will act and it will replenish with the further Langerhans cell that from your bone marrow. Langerhans cell is a myeloid lineage. Your cell, stem cell proliferation is from the myeloid lineage. So from your stem cell, then mature, become a monocyte or dendritic precursor. And all these things will circulate in the circulations and further reside in the skin to replenish your existing Langerhans cell if there is any insult to the skin. And this Langerhans cell activity are mainly you capture these T cell and cause T cell activations and cause apoptosis to your whatever insult that your organs face. So this is a normal physiology of a Langerhans cell. So there's initial theory think that something happened to your skin Langerhans cell, something activated the skin Langerhans cell that it becomes so many of Langerhans cell that disseminated throughout the organ. But this theory do not adequate describe why some patients only have one side, why patients have multiple sides, and why some patients are more severe, why some patients are quite indolent. So with a further define of the lineage of the cell, Langerhans cell, and also with the advance of these technologies, you manage to define that there's a clonal activity in this Langerhans cell, that the theory of the we call it misguided myeloid differentiations model have been proposed to say that the so-called the insult or the activations actually occur much earlier, or it can be a different stage that explain the severity. If the insult happened much earlier at bone marrow, is your stem cell myeloid precursor, or at the circulating dendritic cell or the monocyte, then you may tend to have the more severe form, high-risk multi-system LCH. If the activations occur at the organ or so-called all this tissue, dendritic cell or precursor cell, then you have the more of a low-risk multi-system LCH, or activations occur in the Langerhans cell itself, then it's more towards a single system LCH cell. And also, if it happened at the prenatal, at the fetal or yolk sac, as you know that the cell are just reside in the skin, so it mainly happen in the skin LCH where you see predominantly in infant or early childhood. All right, and also there's some model that explain the neurodegenerative degenerative lesions of LCH on this model. And furthermore, also the chronicity also, we can identify that these MAP pathway activations or the mutation along this MAP pathway are mostly exclusively in this LCH group. And this MAP pathway, if any activations, it causes proliferations, reduce in the apoptosis and migrations, and also a lot of inflammations. So nowadays, pivoting LCH best described as a clonal myeloid neoplastic disorder with inflammatory feature. So it's a combinations, a fusions of the neoplasia and immune dysregulations. So clinical presentation, just echo what Dr. Chai have said. Clinically, we divide in whether it's just one system is one site involvement, which is the most common one, 50 to 60% of the cases, or is a bone involvement but multifocal bone, or you have multi-system means that you have more than one system involvement. And the wrist organ involvement are not so common. It's about 15% of the multi-system LCH. Again, just echo the wrist organ, liver, spleen, and your hematopoietic system. The slide here, just want to show again, it can happen in multiple sites. I think Dr. Chai have mentioned that before also. Just want to highlight here, the most common site, the bone, 70 to 80%, followed by your skin, which is about 30 to 40% of cases. Then you have other side of the body. So again, we have go through the treatments of that patients with LCH. This treatment, the highlight here is the upfront treatment. This is your first line treatment for all those LCH. The International Osteocyte Society have come out with the regimen that they have improved from time from LCH1 in 1990s, LCH2 in 1996 to 2000, and the latest LCH3, which the trial was done in 2001 to 2008, which were the one that we use for these patients. All right, with this 2 cycle of the initial course of treatment followed by 12 months, a more prolonged period of continuation of care. The right side here to show that the overall survival and reactivations are improved the overall survival, and also mainly it reduced the reactivations of disease after remissions. So what's the outcome of the LCH? In general, single system LCH doing very well, especially the bone LCH. They don't almost 100% overall survival and very low risk of reactivations. But these wrist organ have a high mortality. This is the result for from the LCH trial. You have here is LCH 1, 2, 3. I just want to highlight this LCH3 trial here. Overall survival about 90% with 10% of mortality, and reactivations using LCH3 about 25% in general. So again, this is my last slide. So just want to summarize everything on the outcome of the LCH. I think you all know single system, multi-system, and respond to treatments as what we mentioned just now about the treatments. So maybe a remissions, reactivation, or may not respond to a treatment that progress. All right. And the most important thing also, like our patients currently, they are doing well, remissions for the past 8 months, but you may want to monitor for the late sequelae. Of course, those with lung involvement, they may have like if cystic lung changes, you have respiratory failure, or those with liver involvement may end up with sclerosing cholangitis that end up with a fulminant liver failure later after you treated the LCH. DI, we mentioned before, is something permanent that is not reversible. And the very unique thing on neurodegenerations of the brain that may happen after years of your treatment completion and after years of the non-active disease of LCH, you may get this neurodegenerative disease, and also some reported second malignancy in this group of patients. All right, take-home message, LCH is rare in children, but the disease are primarily affecting young children. All right, as an incident that highlighted in the first slide. They have very diverse clinical presentation, but those multi-system risks, we want to pay attention because they have high treatment failure, poor disease outcome, and risk of activations are high. And LCH is a clonal myeloid neoplasia with inflammatory features, and nowadays we know that maybe these MAP pathway activations are the so-called the backbones of the chronicity. I think Prof. Tong, Prof. Phua.
Thank you very much, Dr. Loh, for the very comprehensive case progressed and presentations on LCH. For the final highlight of our presentation today, we're going to have a very quick sharing presentations by Emeritus Prof. Kwa Tuan Chong, who has, as I said, at the beginning of the session just now, has very kindly to jump in on last minute, to replace our initial invite to our previous distinguished expert. So Emeritus Prof. Kwa is Emeritus Professor in the Department of Pediatrik, Yung Lulin School of Medicine, National University of Singapore, and also he's Emeritus Consultant Divisions of Pediatric Hemato-Oncology and at the Department of Pediatric TEMPAT, National University Children's Medical Institute, National University Hospital. Prof. Kwa, you...
Yes, I'm here.
There online, right?
Yes.
Yes, thank you very much. So again, we are very delighted that you are able to join us, and we're going to have discussions, Q&As later as well. So can you see this?
Yes, I can.
Can you see the screen that I'm projecting on the activating pathway mutations in LCH? Yeah,
yes,
so
I can.
this patient has a BRAF 600E positive. So this is the final highlight of our presentations, even though there is a little bit of high-level presentations, but you know that nowadays people go into the genetic profile and those things when going to targeted therapy, when you're talking about any disease, not just talking about Hem-Onc. Yes, Prof. Kwa, all yours.
Okay, thank you. Yeah, this is probably the most exciting part about LCH. Yeah, all along I've been puzzled about the LCH. It's so interesting to manage these kids, but at the same time, for many years, you're wondering what this creature called LCH is. Some call it inflammatory disorder, some call it a sort of cancer, but it behaves actually like both. Yeah, which is very peculiar. Yeah, you get cancer because it forms lumps, there's proliferation of the cells. Yeah, and but to me it is not cancer because almost always the disease undergo spontaneous resolution, which is very peculiar. In about 60 to 70% of patients with LCH. I was so happy. At least there is a defining feature of LCH. Yeah, so there is a mutation in the 600th position of the protein, the BRAF protein, which is a product of the BRAF gene. Yeah. But interestingly, exactly the same kind of mutation is found in other tissues too, which give you the melanoma. In fact, 90% of patients with a melanoma have this mutation. And there are many patients with so-called melanocytic nevi or so-called mole have this mutation too. So it just tells you that a mutation in gene in a cell doesn't always give you cancer. Yeah, so the behavior resulting from this mutation actually depends on, we call it COO, the cell of origin. Yeah. So now we know the mutation. Secondly, as you can see here, not all of them are due to this particular mutation, but we assume that all of them, the mutations come from the same pathway. This is called the MAPK pathway, starting from the extracellular signal. They are transmitted through the tyrosine kinase receptor, and then going down to the RAS, and then RAF, and then MEK, and then ERK. Yeah, so the second commonest, the mutation is found in the MEK gene, which is the third member of the pathway. Yeah, so in the end, we can see that essentially LCH is due to activation of the last member of the pathway, which is the ERK. Yeah, so we can conceptualize LCH as a disease due to activation of the ERK gene, yeah, resulting in the activation of certain of these the gene products, and the what happened after the activation depends on in which cell these mutations occur. Yeah, so as I said, if you can get melanoma, you can get benign lesions and all this. Yeah, so in the LCH, what you get is the in multi-system disease, it occurs in the myeloid precursors. Okay, and which enable these precursors to differentiate abnormally. That's why it's called the misguided disease. Yeah, so it transforms into Langerhans cell-like cells, which apart from the proliferation, it also secretes cytokines, as you can see in the histology. Yeah, it's an inflammatory picture with neutrophils, eosinophils, with B cell, with T cell, and all these kind of things. And this can also cause pain. Yeah, so in fact, some of my patients have a severe scalp pain because of the active lesions in the skull, and then you can feel the lump overlying the depression. Yeah, so this would happen in cases where the disease is active. But the good news is that we do have targeted therapy for this sort of mutated proteins. Yeah, so the for the BRAF gene product itself, we can have the MAPK inhibitor called the vemurafenib, which is a very popular drugs. Yeah, for the MEK mutation, which is the third member of the pathway, we have another inhibitor too. Yeah. Okay. So for patients, about 20% who don't undergo complete resolution with a chemotherapy, vinblastine, prednisone, or second line, then at least we can have a targeted therapy. Yeah. So some people are studying this as a first line treatment, but because these are new drugs, these are expensive. So most of the time in our practice, we only use this as the second line. Yeah. So this is a very nice illustration. Yeah, that this gene mutation may not cause a full-blown cancer, and in the end, it is known that this particular mutation may excite the apoptotic pathway, the FAS pathway. So in the end, the abnormal cells undergo cell death, and also there's inflammatory reaction. Yeah. So this is a very, very interesting disease to have. My old boss, Professor Wok Hong Boon, always taught us, yeah, that even if a disease is rare, it might be very important to know it, because if you don't suspect, the diagnosis that can be missed for months and even years, and these kids will suffer a lot. Yeah, so for LCH, to me, in this particular child, the clinical feature that trigger off suspicion of LCH would be firstly the rash, and secondly their ear discharge. Yeah, so in fairly prosperous countries like Malaysia, the purulent otitis media should not be that common. So if you see a child with purulent otitis media, especially bilateral, you should think of LCH straight away. And then when you think of LCH, as you know, the bone involvement occurs in about the 70-80%. Yeah, so you feel for the skull bone to see whether there's any lump, to see whether there's any depression, and you do a skeletal survey, yeah, to look for osteolytic lesions. So the other very typical lesion, which helps you to recognize LCH clinically, is a rash. Yeah. So the breast can come in all forms, but for me, the most helpful is the seborrhea on the scalp. Yeah, I've seen quite a few kids where the seborrhea was the florid. Yeah, and it can really look very bad. Yeah, so once you have this sort of a very bad seborrhea, then straight away you suspect. So I did know that this kid had a rash on the scalp too. Yeah, so if it is a typical seborrhea, together with the ear discharge, straight away you would think of the LCH. Yeah, so finally, time is running short, but I just want to share with you another disease that illustrates the point that recognizing the features of rare disease is very important. Yeah, on Tuesday, we have ICU round. A case was presented of a child with the edema, yeah, and ascites. And the FBC shows the severe lymphopenia. So once you see this, the hypoalbuminemia and severe lymphopenia, yeah, some of you, yeah, especially the experienced pediatricians would say, oh, okay, this is intestinal lymphangiectasia. Yeah, nothing else would look like this. So I hope at least some of you will bump into LCH or intestinal lymphangiectasia one day, yeah, and recognize them straight away instead of the letting these poor kids suffer for the weeks and months. Yeah, because for both of these, there are effective medical treatment. Yeah, thank you very much. Thanks, Hamidah, for inviting me. This has been a very good discussion. Thanks.
Thank you very much, Prof. Kwa. Stay tuned just another 5 minutes or 7 minutes. So we are going into our final sections of these sessions of panel discussion. I think Dr. David from Surabaya Hospital is also here. Where is my laptop? Hang on. No, poster. Never mind, it's okay. Yep. Right. Is there any questions from the floor that you want to ask our panel discussant? We have our radiologists, we have our pathologists, we have other distinguished, expert in LCH. Just for your information, that we have our Asian histiocytic disease clinical group that we have been regularly meeting online in the past few years and discussing, not to say interesting, these are challenging cases. LCH is a very heterogeneous kind of presentation. And particularly for these patients, does any one of you that have any questions? Dr. Loh, you stand next to me. So does anyone have any questions or you want to clarify anything? Perhaps I start, with a quick question. Yes.
Sorry, Prof. Hamidah.
Yeah,
Before that, I can introduce myself. I'm Dr. Shahrul. I'm actually an adult rheumatologist, not a pediatrician. A very interesting case. I just want to ask, because the pathogenesis of this disease is a mixture, right? And it involved a lot of immune pathways. So are these patients at risk of developing autoimmune disease if, let's say, in adulthood later?
Dr. Loh.
Yes. Sorry, I think maybe we address to Prof. Kwa as well.
Yes, Prof. Kwa. Can you hear that questions from our adult physician?
Oh, yes, I can. Yes. Yeah. So they're very interesting, the question. They are not known to be more prone to autoimmune disease, but they are slightly more prone to some malignancy, including leukemia. And in fact, I have a patient actually who, a young man, who was treated by Professor Lin Haiping, initially for LCH. Then this young man moved to Singapore to study in the university there. And after treating him, he developed Hodgkin lymphoma. So that has been reported, yes.
Does that answer your question, Prof? Yeah.
Yeah.
I wanted to ask Dr. David, with regards to serum galactomannan. This is with regards to this patient. Just wanted to have a better understanding on positive serum galactomannan. So typically, yes, we understand that there's a cutoff point of 0.5 optical density index, or it could be 1, it could be 1.5, a variable cutoff point that been taken. But my question is that when you have a single results of positive results, do you often that needed it to be validated with repeating, or you have a consecutive test and clinical correlations before you decide to treat the patients as, having invasive aspergillus? Because galactomannan, as all of us understand, when it is positive, it indicates a positive aspergillus antigen. So, it tells you there could be invasive aspergillus, unless I'm wrong, correct me, Dr. David, but can you give us a little bit of, enlighten us a little bit on this, and whether is there any conditions that there could be false positive to the results of 118, one something in this patient? Dr. David.
Thanks, Prof. Hamidah. Can you hear me?
Yeah, we can hear you.
Yeah, so the galactomannan, like you mentioned, it's a glycoprotein in the cell wall of Aspergillus. So it tends to be positive when the patients have fungal infections like Aspergillus, but not only that, it can be also falsely positive in other fungal infections such as Candida or even PCP. Normally, values of more than 0.5 in the serum or more than 1 in the BAL will be considered as positive, but sometimes false positive results can occur, such as sometimes the patients were on antibiotics like the beta-lactams because during the manufacturing process, there are galactomannan-like antigens from the fungal fermentation used in the manufacturing process. So some of these can sometimes cause false positive results, even sometimes when the patient takes food like a rice or even pasta. It can also be falsely positive in neonates due to the gut bifidobacterium. So it's not a useful test in the neonatal population. So all in all, when we send the galactomannan results, we also have to interpret it within the clinical context. For this patient, it was sent because the child also had a previous history of a left neck abscess, I think about 2 or 3 months prior to the current presentation. So at one point of time, we were also wondering whether or not this patient was an immunodeficient host. But then when it was positive and with antifungals, within 3 days, it became negative. And the patient was never febrile, blood cultures negative. So all this points towards a false positive galactomannan test.
Right. Thank you. Thank you, Dr. David, for the explanation. I guess I a little bit have some slides before we end, slides of, questions. Prof. Kwa, we know that this patient is, a young patient, BRAF positive, multi-organ, involvement. So we know that the risk of, sequelae or complications with those of BRAF 600E positive. So LCH-associated neurodegeneration, as what, Dr. Loh has mentioned as well just now. My question to you, if this patient have a recurrence of the reactivations of the LCH, what would your thinking or advice for us to treat this patient?
If it is just bones alone, it's good news because we find the biphosphonates to be very helpful. Yeah, so we have given to quite a few patients. It's so impressive that usually the parents would report that this kid, if they have a bone pain, they feel better within 24 to 48 hours. Yeah, and secondly, I love this drug called CDA, which is also used in leukemia. Yeah, but the response to me has been very good. All my patients have responded. The problem is that the original protocol used quite a high dose, so they reported a high incidence of toxicity. But I told myself that the LCH is not a malignancy, so you don't really need a high dose, not like cancer where you have a dose response curve. Yeah, so I cut down the dose and the toxicity no more, and yet these kids respond so well. But with a CDA, you have to be patient because none of the patients respond after one course, usually after 4 to 6. Yeah, but the neurodegenerative disease is something that people are starting to be pay more attention to. Yeah, so in fact, one of the review papers say that this is one of the big conundrum in LCH. What to do? Is there anything that would decrease the risk? Even now, we are not so sure. But now that we have this the method to detect the BRAF mutation, so they found this in the brain. Yeah, so actually this disease is called NDLCH. Oh, yeah, it's a direct cause of the invasion of the to the brain. So in that case, then I think your treatment, as long as the drug penetrates the CSF barrier, it will still work. Yeah, so it's not satisfactory the situation at this time. We are not really sure, but we try our best. I suppose in this case, the higher dose treatment may be helpful. Yeah, I mean, it's just like how we use MTX. Higher dose would give you a higher serum level to allow this to penetrate into the brain. Yeah.
Thank you, Prof. Kwa.
Yeah.
So I hope everyone, have received benefits from this session. Before you take down the poster,
Sorry,
just to let.
Can we have one question? Sorry, about the skin biopsy.
Yes,
Last
please.
questions. For this case, we had skin biopsy where we do not pick up the LCH earlier on. And we also occasionally have experience from our side. The patient had LCH, but when we do a skin biopsy, it does not capture the LCH. So I just wonder how, to Dr. Priya and so Prof. Kwa, how is it because of we do punch-out biopsy. Is it because of the biopsy method itself, or is it the pathologists who report it? Or it is because that the skin lesions yield for diagnosis of LCH may not be very high? Is a question to Prof. Kwa and Priya. Yes.
I think if you look at the slide, only Dr. Priya can find the LCH cells, which she showed to us with this horizontal striae. Yeah, so it's called the kidney bean or coffee bean appearance. Yeah, so it's difficult to find. It's a bit like the Hodgkin. Yeah, when we suspect Hodgkin, we never allow the pathologist to do a FNA. Because most of the cells in the Hodgkin lesion, for example, the pathologists who bother to count the cells, they tell us that less than 1% of the specimen is actually the malignant cells. So you just do a FNA, you're very likely to miss. So it's the LCH is the same thing. Yeah, you have seen the slide earlier. Most of the cells are inflammatory cells. Yeah. So you need a very sharp eye to find the LCH cells. So, but if you do the molecular, the immune phenotyping to look for the BRAF, if indeed this LCH in this kit has a BRAF mutation, then it is would be more sensitive. Yeah. So I wonder whether if you would like to go back to the original specimen and look for the BRAF in this case skin biopsy. Thanks.
Thank you, Prof. Kwa. Any further questions? Right, in the interest of time, we are going to end our session soon, but just, a take-home message for pediatric trainee, postgraduate, undergraduate, you recap and, you work up patients systematically, and you know that this patient, problem, presenting to you with lymphadenopathy and so forth, multiple problem. I have here, a practical algorithm in the pediatric hemato-oncology that is available in the library. I asked library to purchase, and one of our trainee, I gave a copy of the one that I purchased earlier. This is something that, can be useful on your practical daily basis, and then you can filter that to the level of your learning, either undergraduate, postgraduate, trainee. So if you're thinking of how that, you work up patients with lymph nodes, with, splenomegaly, hepatomegaly, and as such, okay? So before you take down the poster, I just wanted to let you know that don't blame us if you see that Prof. Kwa's photo is not actually his physical photo, but there is a very unique photo that he asked us to put up because, that is his patients from Vietnam, right? Prof. Kwa, that came to you, and you have many patients, that come to Singapore for the treatment of LCH. In our experience as well, we have series of LCH patients for many years. Right, can you project the Kahoot? So I hope the undergraduate have wake up. If you listen and involve, carefully in the presentation, you will get the answer. And I have a winner 1, 2, and 3 from my personal token appreciation. You can go and get, a good Godiva ice cream, luxury premium, or, a basic ice cream with some topping. Godiva ice cream is not cheap, You go and buy the soft ice cream one. Satu kon aja sudah RM20, Okay, right. Can we put up the Kahoot? This is for undergraduate. I'm sorry for postgraduate. If there's any postgraduate, you akan dapat the answer. So let's see if the undergraduate can answer. Yeah, before you put up, we would like to thank, each of our panel speakers and experts, distinguished speakers for your, for your time to join us during the CPC. Right, yes. Yeah, okay. Prof. Kwa, thank you very, very much for your kind, participations in this CPC. And Dr. David as well, for your input and, this during the panel discussion. Have a good day, please. Thank you so much. Prof. Kwa is attending a conference in Taiwan, but he put out his time to join us. So
I must say that I'm very impressed with the presentation and the discussion. Yeah, because even back in Singapore, we try to go down to the basics clinical approach. Yeah. And this has been very helpful. I enjoyed the whole thing. Thank you very much.
Thank you. Thank you very much.